All right, good morning, everyone. I'm Alexander Nguyen. I'm a PGY2 here at Augusta Health in Internal Medicine, and I'm accompanied by Dr. Adam Rasool, also a PGY2. Our research this year is a continuation of our research from last year, where we examined more so inpatient palliative care consults and the effect on inpatient length of stay, readmission rates, and overall quality of life for the patient, as well as cost to the hospital. Um, this year, we were very interested in figuring out how hospice consultation actually affects that. Because when you think of palliative care, you naturally think about hospice and vice versa. And I think a lot of our patients have that particular perception too. So, hospice and palliative care has been known for quite some time to improve quality of life and overall, goals of care for the patients with serious illness. Um, we do know that earlier hospice referrals are very good for patients overall. When we think about hospice, we are trying to think of patients that more or less may pass away within the next 6 months or so from diagnosis. However, hospice is often introduced very, very late, often within days of the patient passing away. We use palliative care in our hospital and across the country as a bridge to those harder conversations. And so it's very understandable for patients to associate palliative care, a little unfortunately, with passing away. Hospitalization, however, is a really good opportunity for us to have those really tough conversations. It's when patients tend to be at their most vulnerable. It tends to be when family members from far away come in and visit family members they haven't seen in a while and really have those difficult conversations. So it's a really good opportunity for us to talk to them about those kind of tough decisions. There is a lot of evidence across the country longitudinally to support early hospice care. So anything that's greater than 22 days of being on hospice support does show significantly higher quality of death scores. Hospice overall does reduce healthcare costs. So when we think about decision making for the hospital or any kind of thing that has to do with finances, we do want to think about costs, but hospice and palliative care costs are typically baked into the cake and hidden away. It's not something that generates revenue for the hospital or any healthcare system, but it's something that does save on healthcare costs overall. Hospitals are also the most common hospice referral location. Around 52% of all of our national referrals to hospice happen first in the hospital. And even though, some of us may be interested in doing primary care and we should broach those conversations sooner when you have good rapport with the patient in the primary care office, advanced care planning is also something that we could do in the hospital as well. So I just want to pass this on to Dr. Rasul, who will talk to you about kind of more about our specific study and then the methodology of what we decided to do.
So definitely, hospice is something super important. Palliative care is all part of advanced care planning. We have especially a lot of data across the country that supports early recognition of somebody who would need palliative care or hospice care. Um, we There's some things that we can look forward or see in patients that end up requiring some form of hospice care, um, especially repeated hospitalizations before death. We can note that they have at least one ER visit in the past 6 months and one has hospitalization or admission to the hospital. Um, Creates a lot of opportunities for us to discuss goals of cares with these patients and advanced care planning. And they might not be towards a goal of getting them towards hospice, but just to talk about the future. But despite knowing this, we're finding that a lot of our hospice admissions are coming in extremely late for the patients. So we wanted to try to identify how we can help the institute and our institute identify these patients earlier and give them a better quality of care. So we're looking towards examining the hospice consultation and admission patterns and evaluating the timing of hospice referrals among hospitalized patients who end up passing away and any potential barriers there are to hospice consultation. So looking at the methods of our study here, it's a retrospective descriptive analysis. So we looked at patients who passed away within the past 4 years. So looking at the years from 2022 until 2025, um, all those who passed away within our healthcare system. So those who were admitted to the hospital, and those who actually passed away at the Shenandoah House as an extension of the hospital. Now, we were able to obtain a lot of data from our administrative records, looking mostly at diagnosis codes. Now, what we also evaluated were variables that we can help identify these patients in the future um, earlier on. So different things like when the hospice consultation was implemented, timing that from their admission time, if they had a palliative care consult before this, what type of healthcare was utilized prior to this hospitalization, and a couple other variables as well. So we sort of found that yes, hospice is being coming into play a lot later than it should, right? But we want to sort of figure out why. So the patients interact a lot with the hospitalist team and the residents who work with the hospitalists. So we gave out a anonymous survey to our team here at Augusta Health um, to evaluate everybody's understanding of hospice and where the barrier might be. So it evaluated the comfort and level among providers with when they want to do a hospice consultation, if they're comfortable initiating that consultation or discussion, who's eligible for hospice, and what the perceived barriers among our faculty is for referral.
So when it came to the results of our particular study, we have some good news and we have some kind of less stellar news, I guess, with regard to our inpatient hospice consultation rates. So our hospital is doing a much, much better job of consulting hospice more than before. Since 2022, we have increased our rate from around 23% to around 46% or so. Um, I believe that overall, some of this may be driven from just the fact that around 2022 was kind of the height of COVID. We're kind of seeing a lot more inpatient mortality. And so at a certain point, providers, physicians, hospitalists feel the need that we need to have these conversations sooner rather than later with patients. Um, and also the fact that patients also maybe have had more exposure to the fact that inpatient mortality is a thing, and they're a little bit more sanguine to receiving that kind of information. This slide does demonstrate, however, the fact that despite us increasing our rate of hospice consultation and admission, the rate of, or rather the timing of someone passing away while being on hospice is quite short still. So 26% of all of our patients in 2025 have passed away within less than a day of being admitted to hospice. 54% are within 1 to 3 days. And so if you take those two numbers together, almost 80% of our patients are dying within 3 days of being admitted to hospice. Only 20% of our patients are passing away after 3 days. As Dr. Rasul mentioned before, this slide does demonstrate the fact that even though you think about hospice as someone passing away within 6 months, people are still being admitted to the hospital or being seen in the ED 6 months prior to their death without necessarily being on hospice. And so there are opportunities not just from the hospitalization that they are in right now or their primary care, but ED physicians, other hospitalists from prior admissions do have the opportunity to bring this up to the patient and their family. And maybe that's kind of hard to do so in such a time limited situation. This Sankey diagram is very complex. I find it really hard to interpret Sankey diagram sometimes. The two main things I want to bring your attention to is primarily broken up into the fact that we have a very, very sick population here in Augusta Health. And so there's a multitude of reasons why someone might be admitted to hospice. The largest ones that we saw were people with respiratory disease, primarily COPD, but also malignancy was the second one, and coronary artery disease. The other thing I wanted to bring attention to is how many people from palliative care actually flow into our hospice admission. And so there's a fair number of people who get palliative care first and then become hospice appropriate. It doesn't necessarily mention when those consults happened, but you can kind of understand from a patient perspective why there is such a negative connotation with palliative care associated with passing away. This clinician survey actually had 32 respondents. We had some late respondents come in a little bit later. But in talking to some of our residents and talking to hospitalists and some of our APPs, the vast majority of our providers here at Augusta Health feel very comfortable with initiating hospice consults, which is fantastic. They feel very confident in explaining and being able to kind of figure out who the appropriate patients are. However, if you've ever been on inpatient service, you do realize that it's a very, very busy service to be on. You can be there for 12 hours a day and barely make it out on time, I think, as most of our residents can kind of attest to. So it's really difficult to find time to have those difficult goals of care conversations. Um, there's also a lot of providers who do feel that they don't want to make that final judgment call because sometimes patients can make a turn for the better or make a turn for the worse. Like I mentioned before, there's a pretty big time constraint that hospitalists feel when it comes to sitting down having these sensitive conversations. That's why it's very invaluable that we have our palliative care team here to have those conversations with us and help us with that. And then only 40% of people feel adequately trained to explain hospice, even though they understand generally, if you see it, then you kind of know what hospice is, but you don't know how to necessarily explain every single little detail of what hospice entails. That includes insurance, but also all the services that are included. And so hospice consultation does increase over time. It has increased over time, not just at our hospital, but over the country. We've seen that statistically increase. However, most referrals do occur in the last few days of life still, which is quite unfortunate. And our clinician survey does show that there are delays related to maybe prognostic uncertainty, time constraints, and knowledge gaps. And that shows that it's not necessarily due to any specific individual, but more of a system wide weakness that we have. So overall, like I mentioned before, timing of referral does remain a major gap, and over 80% of our patients died within the last 3 days of admission to hospice. So, if there's any kind of future work that we'd like to do to improve this, it would be probably earlier palliative care engagement, improved clinician education. I think for myself personally, I would benefit greatly from understanding more so how insurance works, how what's exact services does hospice involve, how do hospice nurses, how often they come and visit the home, and that type of thing. And so the overall take-home message is that hospice use is increasing, which is fantastic. I think that that conversation is something that needs to be had with patients, but hopefully having those conversations earlier rather than later, maybe including them in the primary care setting, and improving early identification of appropriate patients would allow most patients and families to benefit from hospice care, not only in their quality of life, but also financially as well. Thank you. Does anyone have any questions? Yes. Yeah, I think that that's a really good question with a multifaceted answer. Um, I do think that a lot of our patients, at least in this area, culturally have never really talked about end of life before. Many of them don't have an advanced care directive. And simply just bringing up the idea and even just asking, what do you want the end of your life to look like? And having those conversations so that they can talk to their family members will be one really good starting point from a primary care perspective. The other thing would be that with regard to overall healthcare burden and healthcare cost, there's a lot of studies that do show that hospice and palliative care do reduce burden on the patient, but also the hospital. And so before we kind of build a patient for something that may not necessarily even want in the long term, it would be good to clarify those goals. Yes, that would be a really, really good determination for sure.
That after palliative care initiation, it did decrease total hospitalizations or ER visits afterwards. And as Dr. Wen mentioned, there's strong data points regarding patients' comfort and how they experience that time frame before passing away, whether or not being on hospice. And there's strong data internationally that there seems to be a nice the golden time frame being from 3 weeks. Not much of a benefit past say 4 to 5 weeks, but that 3 week mark is where sweet spot is.
Yes. That would be a really good, addition to our study for sure. We didn't look at that this time, because we were focused primarily on inpatient hospital consultation, but I do believe just from working a lot with the palliative care team that patients who their main goal is to go home, right? Everyone it's really hard to get someone to go to a skilled nursing facility to get rehab, let alone, telling them that you're gonna be on hospice. At least you can mention the idea that they get to go home with that service. Um, Overall patient satisfaction does increase when you get to go home. That's true. Whether or not that does reduce healthcare burden and actually improve their quality of life if they go to a facility, I think would be really interesting to look at. All right. Thank you.